already spoken, intraocular pressures here will not be 25, 26, they will be around 40.
Yeah.
So that endothelitis along with trabeculitis is very, it is a combined modality. Which comes. So thank you, Dr. Prafulla, for giving me this opportunity and making me part of this instruction course. I also thank APO AIOS for this opportunity. So recurrency is something which is very close to my heart, and because I deal with infections in our hospital in the department, I'm just going to share a story of this 45-year-old gentleman who had been having recurrent episodes since 20 years. And when he came to us, he was on low and on oral as well as topical antivirals, and also low dose steroids were also on, along with artificial tears. So that was like immediately full-blown stromal necrotizing keratitis is something you're seeing. Within 2 weeks, the lesion started responding on an infective level, but immunologically level, it started to thin out. So we went in for AMG and tarsorrhaphy, and with the treatment and palliative treatment, it started to respond. And within 3 months, we were like, okay, the cornea has healed and scarring has started. Patient was started again on prophylactic antivirals so that to counter recurrence, because he was already having recurrent attacks, not using. A compliant patient, he was there. But how much compliance is what you explain to the patient. They do at times, after we had some problem and they immediately stopped it. And once stopping 6 months, he was very compliant. After that, he stopped. And within a week, he came back to me with recurrence. And after prodding, I was taking medications, but I just stopped for 6 days. And then he came with recurrence. As you can see, superiorly, there was an epithelial defect. And then after 10 months, he was again obviously started with full dose antivirals, responded, and then prophylactic antivirals continued. So he's a young gentleman who's been, at times when he comes with the first picture, you feel that you really, it's very difficult to treat and complete loss of vision. But with proper treatment and understanding of the disease, you can manage these patients better now. Before going further and understand the virus. We're dealing mostly, the viral is mainly HSV is the predominant which we know of. It is actually a DNA virus, and that it is a linear DNA which is there with icosahedral capsule which is there, and the glycoproteins which are over there. There are more than 150,000 base pairs on that, and in that linear DNA there are LAT, that is the latency associated transcripts, which are non-coding RNAs. I know it's a little difficult to go back on that, but I would just request you all to just remember the LAT, because they are responsible for preventing the viral replication and suppress the viral lytic cycle. So there is active replication of the virus is something which is stopped by LAT. So I like that virus. I like that non-coding part, because it's going to stop the lysis of the cell, and virus will not propagate. So when we talk of HSV virus, it is basically first going to, most of the time goes to epithelia and the sensory neurons, and then there is one part we all know is a latent infection. And whenever there is a stress or a stimulator factor, again the reactivation of the virus starts. And it is that which will lead to the recurrence of the virus. And HSV can continue replicating in cells, or it will go enter latency by traveling to a ganglion, which most of us know most commonly is the trigeminal ganglion. So with this we know that HSV can exist for a lifetime in the infected host. And as we grow older, the infection chances increases, and there are studies which say that more than 80% of people will harbor HSV in some way or the other. If you go for the classification of HSV keratitis, now the recent classification is primarily on the disease location. It is classified as epithelial, stromal without ulceration, which was initially called as immune or non-necrotizing, and stromal with ulceration, which we used to call as stromal necrotizing, and the endothelial, which initially was called as disciform. And this is now most of us are following, as it is more relevant. The management becomes easier if we go by that. But why are we all here in this room with an IC on a specific part of viral? Because this is a puzzle. HSV keratitis is a puzzle. And mainly because of 3 problems. They have varied clinical presentation, limited treatment options. When I graduated, there was acyclovir and ganciclovir. Today also we have acyclovir and ganciclovir. So nothing has evolved much when it comes to that. unpredictable recurrences. Whenever we feel we've dealt with it, again comes a recurrence. Just before going further, the host immune response in HSV keratitis is also important. And in our body, both innate as well as adaptive immune response is there to combat HSV when it enters into the body. Because the lytic replication is going to take place when the virus will come in contact with the cell, mainly of the epithelium if it is coming from the outside, and it will lead to a raised lesion, and later on it will lead to breakdown. So both the immunity becomes important in that. And there are certain immune cells which become important in pathogenesis. I will not go into the detail of that, but we know that one is the stage 1, which is the rapid response, and the early response and late response. Early is mainly neutrophils, we know that, and in late you will have dendritic, macrophages, natural killer cells, and subset of T cells. The T cells are mainly responsible for the endothelitis or more of the immune component, while the others are for the overall HSV, where it will also go into the epithelium or in the stroma. Now, I have been asked to speak about pathogenesis, so I had to take you all to that level of understanding how it's going to be. So when we go for epithelial keratitis, the pathogenesis is mainly it's coming on the epithelium, the lytic replication where the virus comes in contact with the surface of the cell through glycoproteins and use the host machinery for its replication starts there. First, it will just lead to punctate epithelial keratopathy, then a raised lesion. And most of the time, if our immunity in the form of interferons and HIV specific IgG, IgA is good, it will not go further, and we will not even manifest what is happening. So we will not feel that we've had the disease, and maybe we had some subclinical problem. And sometimes when you just have SPKs and you just give tear substitute, it resolves. That is why when acyclovir was not there, the epithelial dendrite was considered as a I would just say a self-limiting disease like a conjunctivitis, because the host immunity used to come up and it used to take care of that. But these dendrites may also coalesce to form a geographic if your immunity is not good, the immunity of the person and that factor is not taken into account. The stromal keratitis, when it occurs and it goes more deep, there will be an early phase as well as a late phase. So again, a triad of immunopathological problem which is happening, because early phase will have more of neutrophils, and in the late phase it will come up again. Here it will not cause lysis, but it will lead to angiogenic. That is why most of the viral keratitis, if it is stromal or below, it usually leads to neovascularization. The scar with neovascularization we say is because of viral. That's one of the differentiating when we go for scars. And that's how it presents over here. And if the invasion or the evasion, whatever is powerful, it will go to that level of that. When we talk of endothelitis pathogenesis, as I have just said, that it is more immunological, and there are recently now only animal studies which actually have proven some part. It's usually said that it's a combination of the CD4 cells and also the inflammatory milieu which is created by the HSV corneal infections. That is a non-specific binder. But mainly the T cells are the ones which get excited, and they act on the endothelium per se, leading to damage of that cell or lysis of that cell and leading to edema, because that is not functioning much. And later the surroundings one will go over there. And once you suppress it with steroids or other immunomodulators, it is going to, the damaged cell may recover or it may die forever. The second problem which I was just saying was unpredictable recurrences. So this was one of the cases, came to us so bad, every time it was perforated, we didn't have much of an option not responding to medical therapy. At this phase we do not. We had no option but to go in for therapeutic keratoplasty, and under strong full antiviral cover, like a 5 times the oral as well as topical. But again, even with that high dose, it did develop recurrence. I would not even call it recurrence here. I would just say it was more of a residual infection which was still there, because however large a graft you take, it may have disseminated beyond that. This was another case what I was just talking about, post-operative corneal edema which was present, and more so at one area, but a diffuse corneal edema, thought of as PBK, operated for DMEC, and later on developed on the epithelium the geographic sort of ulcer, because obviously the patient was on steroids but not on any oral antiviral here, because we did not. And finally, when kept on that, it did resolve. So why does recurrence actually happen, and what makes this HSV1 latent? Again, we had spoken about LAT. It plays a crucial role in the latency because it has two factors. It represses the transcription, which halts the lytic cycle, so it will make it dormant. It will not allow the virus to replicate more. And also, sometimes, whenever there is a reactivation trigger, it is going to cause a problem. Now, why is it important for us is, as a clinician, we are happy if the virus remains latent. So, I'm happy if it is latent and not causing any immediate problem to the patient, because we know it's harboring there. So, can we find out how it is? So, neuronal latency is on the ganglion, but is there a non-neuronal latency also there? There have been studies which show that viral latency in retina and cornea is there. But it's still an area of controversy, and a lot of studies are going on to prove it. But why do some develop and some do not develop? We just know that there are evasion strategies which are there, which is because of the immunity. And there is, again, if you look at the pathogenesis, there is lysis happening, but if the immune response in the HSV evasion strategies, having those interferon gammas there, that overtakes, the infection will finally halt, or it will not allow it to occur. But there are certain key cytokines which are there, and some which will halt the viral replication and which will cause inflammation and neovascularization. But a balance is needed so that there is minimal scarring which happens. A lot on the molecular level. I'm just going on this one-eyed patient who had again a recurrent keratitis, presented with perforation. We went in with the cyanoacrylate glue, responded, stopped ACVir after some time, and then again had a recurrence there. So how to treat them? We are clinicians here. Finally, we need to treat recurrence. A very good study on form of head study has been done, and a lot of credit to whatever we do in viral goes to this study, which was a randomized double masked study in 1989. And I would just go to that level where because I'm dealing with recurrence. So a recurrence, when they did the second part in the head study, was the prevention trial where acyclovir 400 milligram BD was done, and it reduced the recurrence to 41% and 50% decrease in more severe keratitis. We all still follow that. But if you look at it, there were certain limitations of this study. If you go into the depth, you realize the dosage which came was from dermatology. It did not come from any human trial, that why 400 milligrams should be adequate for me or for somebody who's 40 kg and somebody who's 60 kg have different immune profiles. So we still don't know what to do. And there were others, but this was what is pertinent to us. So this is a very recent 2025, still in print, and it gives us the clinical strategies for prevention. There again, we have limited drugs in form of nucleoside analogs, acyclovir, ganciclovir there, where they actually inhibit viral DNA polymerase. And resistance is also now, which is noted, and I will not go into the molecular level, but yes, oral antivirals do well. So to summarize what was there, the tablet, I'm talking of acyclovir more on our context, 400 milligram BD is something we normally do. And again, what we know that less than 50%, it will not allow the recurrence to occur, but still it can recur even on that. So sometimes I feel it's not because the coverage was not, maybe the dose for that individual was inadequate. So in the next time, you have to increase the dose. Periodic RFTs are needed, but it's a very safe drug, and ideally it's a lifetime prophylaxis or for recurrence which has to be taken. And when I was going through this article, I realized even they agree to what we all discussed, that optimal recurrence-free interval before corneal transplant is not definitively established. A minimum of 6 months is something we all agree. 1 year is something we all follow most of the time. So if I go again with this patient, where the patient presented with infiltration and melting, resolved with antiviral treatment, but again stopped, we went in for keratoplasty after a year. It again had a recurrence for that. So recurrence are there. So can a biomarker predict recurrence? We have studied so much about immunology, but when should we know this patient will recur and this may not? So there are some cytokines which are there, which may help us in predicting can there be recurrence. Just 1 minute of that. This was one of the patients who presented to us, was on, we started on oral antivirals as well as topical with steroids, and we started doing gene expression level of a particular biomarker, which was IL-6 here, and we found that at the very presentation it was high. When responded, it reduced. but again came with the recurrence. And if you look at the third visit, which is there, it again showed an elevation, which means that somewhere it's not, it's increasing, but with the recurrence. It's not there with when the patient was responding. So patient again, when they stopped and had a recurrence, and once 2 months later, when the patient was on oral antivirals, the levels of the biomarker of the IL-6 again came down. So maybe this may be one of the markers which can, levels of these markers, which can tell us that, okay, now it has come to quiescence, can we go in for that? But it is not something which is immediately there. There is need to understand HSV keratitis better and at molecular level. We at our hospital were treating it in clinics till 2022. Now I am moving from with clinics to the molecular lab with scientists and trying to come up with some biomarker identification. That has been my pain point. How I should be able to differentiate that this may progress and this doesn't need. Because starting long-term therapy in any patient in our country is not a very easy job. Tell them you use it for lifetime, it's not easy for them to afford. It is a 30 rupees therapy for a day for our patient. And you go even in the Pradhan Mantri Yojana, if you send them to the least cost effective, if you want to go in for the cost effective ones. So translational research is something we need to do now, and these are the ongoing projects which we are working on HSV keratitis in our hospital, where we are studying by various markers and how we strategize later on that how we are going to treat them, common modalities of epigenetics and also mesenchymal stem cells. These are the publications which we've had so far, and the awards and the allocates for our various scientists and students in various conferences. Thank you so much for your patient hearing.
Thank you so much, ma'am. Definitely we need a lot of understanding